So, good evening, all the aspirants, or more aspirants will be joining us. So, today we have the class on cardiovascular disease. It's a CCS session which will be taken by Dr. Varun Pushkarna, sir. He is a senior consultant internal medicine at Fortis Escortis Hospital, Amritsar. So, you may take over. Thank you.
Yeah, thank you. So, good evening, students. We will be having a case, and probably, if time permits us, we'll discuss another case which is very close to my heart, and it is also very important. So, we will begin with this case is the infernal MI. We usually see that usually there is this one patient of uh, acute myocardial infarction that takes us through almost all the stages of management of a patient who is admitted to you with myocardial infarction. So we will try to go step by step, trying to manage as and when the situation arises, and we will have an interactive session. So may I know how many students are there today, Sana? So we have 10 participants, out of which 8, 7. All right. Doctors, I would like to have you all on the board. So at the end of this session, you should be able to identify, to recognize and manage the combinations of as and when they arise. Try to teach them, then try to manage according to the severity of the situation. So, be it arrhythmia, be it complications. So, these are the important things required from when you are appearing in an EDIC examination. I hope the screen is clear and visible to you. So we have a 58-year-old male who has dyslipidemia. You can advocate who is in the department with chest pain radiating to left arm with sweating and vomiting. Now, if this patient presents to you in the emergency room, I will have 3 questions for you. Number 1, what are your initial 3 priorities in this patient? Number 2, if you are suspecting an MI, what biomarkers are you going to order? What ECG findings do you expect? And what ECG findings do you expect to confirm a STEMI? The third thing that I would like to know from you is what would you do if this patient has a STEMI? Would you thrombolize or would you proceed to PCI? So any one of you can turn on your mic. You can tell me, think, it is only that opinion. What are your priorities? Diabetic, dyslipidemic, chronic smoker, 50-year-old male, chest, idiot, arm, 10 on scale, and 1.
Okay, sir. For me, my initial 3 priorities would include having an urgent ECG and then collect blood samples and set for estimation of the cardiac biomarkers, and then resuscitation with oxygen and analgesia.
Anything else? So when all of you are appearing in EDIC exam.
Yes.
So you must start with ABC.
Okay, sir. Noted.
These are your first 3 priorities. Everything else can wait. But ABCs must discuss. Whenever you say ECG, make a habit of saying that the acute coronary syndrome into unstable angina, then non-STEMI and STEMI. So can you tell me the difference between unstable angina and STEMI, non-STEMI? or myocardial infarction and unstable angina? Anyone? What is the difference between unstable angina and myocardial infarction? This is a
Okay,
very important
let me
question.
try. Yeah. In
Yes, go on.
in NSTEMI, the patient presents with a classical chest pain of acute coronary syndrome, which occurs at rest. But the
Wonderful.
ECG will be normal.
Wonderful.
Will be normal, and then cardiac biomarkers may not be elevated.
So chest pain can be absolutely correct. So chest pain can be classified into unstable angina and MI based on, because both of them may have ECG changes. Both of them can have ECG changes, but the biomarkers, they will be absent in case of unstable angina, and MI means infarction. Infarction means release of troponins and CPK-MB into circulation, myoglobin into circulation. In unstable angina, it's crying out of help because the circulation is not enough. So if the patient has an ST elevation MI, then you would consider thrombolizing the patient if the nearest PCI center is 120 minutes away. So you'll thrombolize it. In case you have a system in your own hospital, then you do a primary PCI.
Well, sir,
So we'll
sorry to
move on to the
interrupt,
next
but
slide. The assessment
hello.
is what priorities should.
Sir, sorry to interrupt, but I believe that we
Yes.
are facing some technical problem. Actually, sir, your voice is breaking a lot. I think there is some network issue.
Okay. Okay. Let me see what I can do. Am I audible now? Hi, Sana.
Yes, sir, you are. It's better.
It's better, right? So the first priorities are, number one is to get your ABCs. Hello.
Yes, sir. Yes, sir, we are still having some problem.
Okay, because from here the networking is excellent. I don't know where the issue is. I'm having a very good signal here.
Okay, sir.
Everything is
Okay, sir, you may
fine.
continue.
Yeah. Okay. So place continuous cardiac monitoring, that is with an ECG. Maybe if the patient is going into shock, arterial BP monitoring. Administer only if the saturation is less than 90%. Then immediately move to rapid diagnosis of STEMI and non-STEMI. Get a 12 lead ECG as fast as possible. Look for ST elevation. It carries maximum marks in the ECG. If you see a new onset LBBP or any dynamic changes, for example, T waves getting inverted, the ST starting to go up, rocket like T wave, tall T waves. So these are all hyper, tall T waves. They can be present. Then, of course, send cardiac biomarkers like troponin I, troponin T, and then get a bedside echocardiography. So these are the most important things that you can do to diagnose a patient of STEMI, non-STEMI. Basically, the problem that we keep facing is whenever the patient comes to the emergency room or even in the ICU, the patient has chest pain. The immediate thing that we need to decipher is that whether this chest pain is due to a heart attack or not. If it is a myocardial infarction that is happening and you miss it, it is, it is not expected of an intensivist. So the chest pain has to be followed into an algorithm immediately After confirming your ABCs, you need to get the ECG done, the biomarkers done, and yes, the serial ECGs also have an importance. If something is not shown in the first ECG, repeat the ECG after 30 minutes if the chest pain is ongoing. Of course, analgesia is very important. Giving morphine is, is a good thing to do. Immediately give it. These are the few drugs that are expected from you to know. It is by the mnemonic of MONAS. So M is morphine, O is oxygen, N is nitrates, A is aspirin, and S is statins. So this is the bare minimum that you need to give, along with an anticoagulation, that is low molecular weight heparin. So these are the time critical therapies that should be given to the patient who has come to you with suspected myocardial infarction. If the patient has a STEMI confirmed, then you should activate the cath lab as soon as possible. The door to needle time has to be less than 90 minutes, and this the ballooning process should be finished within 2 hours. That is 120 minutes. If you suspect that the nearest center is far away, it's like beyond 2 hours of distance of traveling, that the patient may not reach the center in 2 hours, then thrombolizing the patient will become a priority. So the loading doses of aspirin 300 milligrams along with the P2Y12 inhibitor, that is either clopidogrel or a ticagrelor, should be given. This is known as a DAPT, dual antiplatelet therapy, plus a statin along with a heparin or low molecular weight heparin. Nitrates are indicated if the blood pressure is more than 90 and patient does not have an inferior wall MI. In our case, the patient has an anterior wall MI and the patient is having ongoing chest pain. So either NTG infusion along with a heparin infusion can also be given. That is based on the discretion of the treating doctor. If they feel that the blood pressure is high and the patient has high risk of collapsing, then you can start NTG infusion along with heparin infusion. Important thing to remember is that diagnosis, stabilization, and early reperfusion defines the cornerstone of management of coronary artery disease or ST elevation MI. These are the initial golden minutes of myocardial infarction, and it has been proven time and again that it improves the overall survival.